So, first presentation by Eveline Regar, 30 years of intracoronary imaging, milestones and lessons learned.
In Europe, it all started with Niklas Bohm. He was a maritime engineer at the Thorax Center in Rotterdam. In the 1970s, he applied the principle of sonar to image the human heart, which eventually became echocardiography as we know it today. And he also continued to explore the use of ultrasound for intravascular imaging. And he came up with a number of solutions. This is a catheter from 1980s carrying a transducer at the distal tip, and you suggested already phased array transducers as well as single rotating transducers as we use them today. It then, of course, took a woman to ensure that this catheter was to be used in patient, Elma Gussenhofen. She wrote to me, "I do remember the very first patient in 1989. We performed imaging with a catheter that was sterilized at the Agriculture University of Wageningen using gamma radiation. There was one single catheter in between cauliflower plants. I had to travel there to pick up the catheter personally to make it in time for the intervention." Well, Elma did. She made it in time. And soon later, John Hodgson and Stephen Nissen started their intravascular imaging programs in the US. It was fascinating to see this. As a community, we just needed a handful of human cases to understand the superior sensitivity of intracoronary imaging for plaque detection. We observed that coronary artery disease was often present but missed by angiography, and that was against the dogma of the time. We continue to observe that coronary artery disease can be modified, for instance, by high-intense statin therapy, reducing plaque volume. Plaque volume is of particular interest as it plays a prognostic role, especially when combined with structural components as visible by optical coherence tomography, like fibrous cap thickness, calcification, thrombosis, and near-infrared spectroscopy, lipids, specifically cholesterol esters, and lipid core burden. With the advent of these two technologies into the cath labs, we got a tool in our hands to study structural and compositional plaque changes in humans over time. That led us to the important observation that clinical events are driven by plaque extent, as we knew already, but also by the presence of lipid core plaques. That is important because we learned over the last couple of years that lipid core plaques can be reduced by medical therapy, and even more astonishingly, we learned, and this is data coming from South Korea, medical therapy along with preventive PCI is even better than medical therapy alone when it comes to clinical outcomes up to 2 years. So this is interesting. We are here connecting the dots because as it happened, we were also studying PCI and the concept of imaging-guided PCI for 30 years. Already in the first decade of ultrasound use, we had conceptualized the approach of IVUS-guided stenting. Already at that time, we knew exactly what stents to choose with size, post-dilatation, with length. We understood the landing zones, which reference segments to select, and the value of antithrombotic therapy. However, we failed, and we failed miserably to prove the prognostic impact on restenosis, at that time, bare metal stents. So it took a while, and it took until these days that we as a community were able to design and to conduct the clinical trials necessary to prove our point, to prove that intracoronary imaging-guided PCI indeed reduces major adverse cardiac events. Today, this resulted in Class 1A recommendations. Intracoronary imaging guidance by IVUS or OCT is recommended when performing PCI on anatomically complex lesions. And this is true for chronic as well as for acute coronary syndrome. Well, I showed you a couple of examples out of 30 years intracoronary imaging, about 20,254 scientific publications as of last week, and I demonstrated you how we evolved from studying the pathophysiology of our very intervention, how to treat lesions, into understanding pathophysiology of atherosclerosis in patients over time, what to treat, and we are today in the position to solely focusing on the prognosis of the patients. The question in our days is how to prevent. How to prevent PCI that is unnecessary, how to prevent treatment failure when PCI is indicated, how to prevent repeated procedures because of inadvertently lesions missed behind, and how to prevent clinical events. So, in conclusion, today, intracoronary imaging makes you an even better interventional cardiologist. It enables you to make a difference in coronary artery disease and to save lives for our patients. Thank you very much.
Okay, thank you, Eveline, for the elegant summary of 30 years history of IBI. And next speaker will be Professor Joo-Yong Ahn from Samsung Medical Center, and he's going to talk about the IBI predictor associated with TLF after complex PCI. Dr. Hahn, please.
Thank you, Chairman. Good morning, everyone. This study is the secondary analysis of the Renovate complex PCI. These are my disclosures. I can skip this slide, thanks to the previous speaker. The Renovate complex PCI was an investigator-initiated, multicenter randomized, open-label trial that was conducted at 20 sites in South Korea. Patients with complex coronary artery lesions undergoing PCI were randomly assigned to undergo either intravascular imaging guided PCI or angiography guided PCI in a 2-to-1 fashion. For patients who had been assigned to the intravascular imaging group, the choice of IVUS or OCT was made at the operator's discretion. The primary endpoint was the target vessel failure, defined as composite of a cardiac death, target vessel MI, or clinically driven TVR. During a median follow-up of 2.1 years, the cumulative incidence of the target vessel failure was 12.3% in the angiography-guided PCI group and 7.7% in the imaging-guided PCI group. The difference was statistically significant, and the hazard ratio was 0.64. The benefit of intravascular imaging was mainly due to reduction in cardiac death in the intravascular imaging group compared with the angiography guided PCI group. In the Renovate complex PCI, the stent optimization was defined as sufficient stent expansion without major dissection or major malapposition based on expert consensus document of the European Association of PCI. The sufficient stent expansion included an MSA greater than 5.5 square millimeter by IVUS and greater than 4.5 square millimeter by OCT, or MSA greater than 80% of the mean reference lumen area in non-left main lesions. In the exploratory analysis, patients in the intravascular imaging group with stent optimization, the lowest incidence of the target vessel failure, 6.0%, followed by those in the imaging guided PCI group without stent optimization, 8.9%, and the highest among those in the angiography guided PCI group, 12.3%. Unfortunately, stent optimization was achieved in only 45% of patients in the intravascular imaging group, suggesting both the importance and the challenging of achieving stent optimization. However, the prognostic impact of suboptimal findings on intravascular imaging, such as absolute or relative stent expansion, malopposition, or dissection, is unclear in complex PCI. Therefore, in the secondary analysis of the RENOVATE complex PCI, we sought to evaluate the prognostic impact of suboptimal findings in intravascular imaging following complex PCI using contemporary DES. Of 1,092 assigned to the intravascular imaging guided PCI group with 1,623 lesions. We focused on the non-left main lesions. After excluding patients with left main lesions, finally we enrolled 714 patients with 897 lesions at major epicardial vessels. The best cutoff value of the final MSA for the risk of target lesion failure was 5.5 square millimeter, corresponding to the traditionally recommended value. Patients with the MSA smaller than 5.5 square millimeter had a significantly higher risk of target lesion failure than those with MSA of 5.5 square millimeter or larger, 2.2% versus 4.8%. In lesion level analysis, the left LAD lesion and device LAD lesion was found more frequently, and the device diameter was smaller, and the stent length was longer in the MSA, smaller than 5.5 square millimeter group than in the MSA of 5.5 square millimeter or larger group. CTO and diffuse long lesion were found more frequently in the MSA, smaller than 5.5 square millimeter group, compared with the MSA of a 5.5 or larger group. Relative stent under expansion, any dissection were found more frequently in patients with MSA smaller than 5.5 square millimeter. However, any malopposition and major malopposition was less frequently found in the MSA smaller than 5.5 square millimeter. MSA was the only important predictor of the target lesion failure, relative stent expansion, and a major stent malopposition and major stent edge dissection were not significantly associated with the risk of a target lesion failure. When we incorporated the MSA and made other suboptimal findings, such as major malopposition or major dissection, patients with MSA smaller than 5.5 square millimeter had the highest incidence of the target lesion failure. However, there is no significant difference according to the other suboptimal findings in this group. Among patients with the MSA of 5.5 square millimeter or greater, patients with other suboptimal findings tended to have higher risk of target lesion failure than those without other suboptimal findings. This slide is my last slide. In the secondary analysis of Renovate complex PCI in 740 patients with 897 lesions, in non-left main lesions, the MSA was the only important predictor of the risk of target lesion failure. The best cutoff value was 5.5 square millimeter. However, in patients achieving MSA of 5.5 square millimeter, other suboptimal findings such as major malapposition or major dissection may have a prognostic implication. Thank you for your attention.
Okay. Thank you, Professor Han, for the very detailed analysis. Next speaker will be Jung-Min Ahn from Asan Medical Center, and he's going to talk about the criteria for left main bifurcation PCI. Please.
Thank you, thank you very much, Dr. Gu. So we have two different randomized trials to guide the left main bifurcation treatment. One favored upfront two-stent technique, the other favored simple crossover stenting. So I think that this study's message is select left main bifurcation strategy wisely. How to select wisely. So, but the two studies, the literally same criteria, but the procedure would be different. DK Crush 5 study, in provisional group, two stenting was 75% finally. But the EBC main trial in provisional group, two stenting required in 22%. So I think a DK Crush group may have a higher complexity of distal left main disease. Anyway, so many left main disease. Which left main disease do you prefer, the one or two stenting? So every apparatus may have different ideas. So simple crossover or sometimes bypass surgery, sometimes simple crossover 1, 2, 3, 4, or the two stenting 4, 5. So we have only one criteria to guide the simple crossover or upfront two stenting, the definition criteria by Dr. Shaolin Chen. So, but this is the angiographic criteria. You know, the angiographic criteria may not be reproducible and larger variation, the interpersonal variations. So usually in our cath lab, we depend on the IVUS findings, particularly the circumflex ostium. Upper panels and lower panels, true bifurcation, but upper panels, the IVUS findings show the circumflex ostium, the huge plaque, small lumen, but lower panels, normal circumflex ostium. So upper panels, we treated upfront two stent technique, lower panels just crossed over. The beauty of intracoronary imaging, it would be that we can measure the number, so we can get the numbers. We can communicate with others using number. So I'd like to introduce our recent observation. So how to treat the imaging based decision for left main bifurcation treatment. The PCI bypass surgery issue, I think, would be resolved based on the IPD meta-analysis. No difference in the survival between PCI and bypass surgery for the treatment of left main. Then next issue would be the how to select the left main bifurcation strategy, provisional stenting first or two-stent technique first, and how to optimize the left main stenting result. The first, how to decide the provisional stenting first or two-stent technique. Based on our left main registry, we focus on the circumflex ostial minimal lumen area and plaque burden. So we have 278 patients evaluated circumflex ostium by IVUS before procedure. So to provisional stenting group, the minimal lumen median value is 3.8, plaque burden is 50%. Upfront two stenting group, minimal lumen area is 2.3 and 74% plaque burden. So we already selected the patient wisely. Small lumen, large plaque burden upfront two stenting, and large lumen, small plaque burden, simple crossover stenting. So in addition, after simple crossover stenting, we evaluated the acute procedural complication. What is the acute procedural complication? Barrel stenting, hissing balloon POBA, low FFR, et cetera. So it occurred in 19 patients out of 278 patients underwent simple crossover stenting. Incidence was 6.8%. To predict the acute procedural complication, best cutoff value of minimal lumen area and plaque burden was 3.7 square millimeters, plaque burden 64%. This is actually very similar to the previous Dr. Gang's data. Dr. Gang's evaluated predictors of functional jailing after simple crossover stenting. She defined the two criteria: minimal lumen area less than 3.7, plaque burden more than 56, can predict the functional jailing after simple crossover stenting. So if two criteria combination, small lumen, large plaque burden, composed of 15% of simple crossover stenting group, showed a very high risk of acute procedural complication. 1 out of 3 patients after simple crossover stenting, if a patient had a small lumen and large plaque burden at the circumflex ostium, suffered from the acute procedural complication. But the large lumen, small plaque burden, or one component, the acute procedural complication rate is very low. So in addition, 5-year follow, such a patient, high risk, one stent provisional stenting patient, its event rate is higher than 2 stent well expanded upfront 2 stent patient. So if we select the upfront 2 stent technique, I think the long-term prognosis would be getting better than the simple crossover stenting in those high-risk population. So I think how to decide the simple crossover or the upfront 2 stent technique based on the circumflex ostial disease status, the minimal lumen and large plaque burden. So small lumen, both small lumen and large plaque burden, initial 2 stent technique would be better than simple crossover stenting. So there are many stenting techniques, 2 stent, simple crossover, even 2 stent, many stenting techniques. So I do believe, personally, I do believe any kind of bifurcation stenting technique, I think the stent optimization is more important to get a good long-term outcomes. Previously, Dr. Gang published the very popular numbers, 5, 6, 7, 8. But these numbers came from the 9-month In-Stent restenosis predictions. Up to 2 years, a very good prediction of 2 years outcomes. But the exact criteria are a little bit different. The Europe criteria are a little different. But recently, we defined this criteria against the 5-year MACE rate. For the 2 stent technique, we evaluated this left main LAD ostium, circumflex ostium. Unfortunately, this left main cutoff value was 11.8, but not associated with outcomes. But the circumflex ostium, very linear relationship, LAD ostium, very linear relationship. The 80.3 was the cutoff value, very nicely predicted the 2 stent techniques outcomes. Circumflex ostium 5.7 also very nicely predicted the 2 stent techniques outcomes. If there was both LAD and circumflex under expansion, clinical outcomes huge, clinical event is huge increased in those population. I'd like to apply this idea to the provisional stenting group. We evaluated the proximal left main, distal left main, and proximal LAD. 3-component cutoff value was 11.4 for proximal left main, associated with the outcomes, and minimal stent area distal left main 8.4 and 8.1 is significantly associated with simple crossover stenting outcomes. So similarly, both on the expansion in 3 segment increase the risk of clinical event. So this is my summary. New imaging algorithm for this left main treatment. Look at the circumflex by imaging. High risk initial upfront to stenting, and low risk provisional stenting would be good. After stenting, do optimization according to the minimal stent area criteria. So apologize for the many numbers. It's just a benchmarker. So I think the chasing this target goal, the standardize the procedure and improve outcomes. In addition, the IVUS guidance is you need to guide some action when you see the IVUS. So just watching without action won't make a difference. Thank you for your attention.
So next is Akiko Mehara, who's going to talk about chronic stent recoil, an emergent mechanism of in-stent restenosis.
Okay, so this is very provocative data. So when we look into the in-stent restenosis, we see the old stent was under expansion, or good expansion, a lot of neointima, or different type of the neointima, or neoarteriosclerosis, including repeat or calcified plaque. That we see as a cause of the in-stent restenosis. So when we focus, such as under expansion, this one is due to the calcium behind the stent, and this one is under expansion due to the actually myocardial breach. And both are, stent was very small and a little bit small amount of the neointima population. So we ask whether late chronic recoil occur or not in the long time ago. That's the first generation DS. At that time, we have only 54 regions, which having the 2-time IVUS between the about 3 years. And then in this paper, we conclude only 2 regions show the stent recoil defined as more than 50% of the decrease. So our conclusion was stent recoil is very rare. I'm talking the chronic recoil, right? Next, we did the very small study, 28 regions, and all regions was very severely calcified and treated by rotor. And our main purpose of this study is really to check the healing process. It's not recoil at all. But when we look into this case, for example, if you see very carefully, if you look into simply, you don't recognize stent area is different. But if you measure very carefully, actually, you see the stent area decrease at the mid-segment. So actually, stent recoil may occur. And in this study, using more than 50% of the decrease as the definition of the chronic stent recoil, we see 1/3 of the cases having the chronic recoil. Additionally, we ask why, and what is the segment causing the recoil? And then we ask 2 things. Number one, this is, we thought, kind of like calcium with lipidic plaque. At the follow-up, we see the no attenuation, that's meaning more advanced calcium. So maturation of the calcium could make cause, that's number one. And second is non-calcium side, we stretch a lot, that's may cause. So we ask 2 separate questions. And when we compare the baseline follow-up, with attenuation, decrease, and without attenuation, it's actually increase. So during the follow-up, those calcium actually get mature. And then we analyze very crazy way, meaning this is a non-calcium side, this is a calcium with attenuation, we think that's some lipidic plaque, and this is a calcium without lipidic plaque. And then we analyze baseline and follow-up side by side. And then we found actually the major contribution is really non-calcium segment. So calcium segment didn't change at all when we measure the circumflex baseline follow-up. So seems to be in the calcified region, we stretching the non-calcium side, that's causing the stent recoil. But this is still 28 region. Then we go to the larger study. So this is 2 times OCT at the baseline follow-up, 265 region, and half of them was actually TLR at the second time, and 1/3 is no TLR. In some reason, they did OCT again. And we defined the chronic recoil 2 times. One is you see the deformation of the stent. This is only 1 stent, but at the second time, you see the double layer of the stent. This is really the deformation during the chronic stage. So whenever we see like the deformation of the fracture, even 1 slice, we consider stent recoil if that is more than 10%. But without those mechanical issues, like this case, you see the baseline is 5.5 and follow-up is 4.1. And for this, we have to be very careful because angulation of the OCT catheter may increase the visual lumen or stent area. So we're picking up the largest recoil site, and then we go to the proximal distal 10 millimeter, and total volume of the stent, if that is more than 10% reduction, we consider the stent recoil. And this is the data. When the region causing the TLR, chronic stent recoil defined more than 10% of the decrease of the stent area is 21%, but no TLR is only the 8%. And we ask, what is the cause? What is the associated factor by morphology? And we see the more calcium is more likely recoil, and more stent expansion is more likely recoil, and asymmetric stent expansion. So that really makes sense compared to what our previous data, meaning when we're talking the calcified region, if we don't modify calcium enough, and then we're stretching the non-calcium side, the more likely eccentric stent expansion causing the stent recoil. And this is all recoil cases, and then we ask, what is the contribution of the recoil? What is the contribution of the neointimal hyperplasia? And about 2/3 is neointimal hyperplasia, and 1/3 is due to the recoil. And then we ask, what is a morphological factor to be associated with TLR? Is really the baseline large stent area is good, but more recoil is bad, and more neointimal hyperplasia is bad. So we thought most of the time when we see the small stent area, that's starting from the beginning, but actually some of them could be chronic stent recoil. And this is a different data. We analyze right coronary osteal in-stent restenosis, and I do think this is probably the place which we see the more recoil. Out of those, we see the stent fracture is about 1/4 of the cases. So right coronary ostium, that could be the more vulnerable segment which causing the stent recoil. This is a one case example, baseline 6.4 and follow-up 5.4. Okay. So to summarize, this is please consider this is really the retrospective study, and the cohort is very biased. So please don't overreact. But I do think the summary was very rare of the chronic stent recoil in the first generation DS. But second generation DS recoil, we can consider about 20% in the restenosis cases, but if no restenosis, is 8%. And that occur at the non-calcium circumference and very rare in the calcified segment. So predictor of the recoil is more likely big calcium and asymmetric stent expansion, meaning we stretch a lot for the non-calcium segment that's may causing the recoil. And contribution to restenosis of the recoil pattern is 1/3, and 2/3 is neointimal hyperplasia. So this is one of the pattern which we should consider as a part of the cause of the restenosis. Thank you.
Okay, so the next speaker will be Professor Greg Stone from United States, and he's going to talk about the meta-analysis using ILUMIEN 4 and ECLIPSE. Professor Stone, please.
Thanks. Well, this will just give us an update of where we really are on the use of intravascular imaging to guide PCI procedures. So the recent guidelines have finally recognized that intravascular imaging is very important by providing a Class 1A recommendation. The most recent European guidelines are in chronic coronary syndromes, Class 1A for intracoronary imaging in complex lesions. And in the United States, the most recent guidelines are in ACS, and it's also Class 1A, again, in complex lesions. So a lot of this is based on now just the summary of all the data that we've got, and we put all this together and published most of it in The Lancet in a pretty high publicized article because it showed some new data. And we looked at 22 randomized trials over 13 years of drug-eluting stents guided by angiography or intravascular imaging in nearly 16,000 randomized patients, and you can see there were a lot of patients with both angiography, IVUS, and OCT. And we looked at follow-up ranging at about 2 years on average, between 6 months and 60 months. And we did a network meta-analysis. This describes the network, which I won't go over in detail, but in a network you look at both direct levels of evidence and indirect levels of evidence, and hopefully they are concordant. So overall, we had, you could see for IVUS, 4,888 patients, for OCT, 3,831 patients, for the combination of IVUS or OCT in a non-stratified fashion in Renovate, 1,092 patients, and then angiography, 6,153 patients. So our primary endpoint was target lesion failure, and this is the direct level of evidence from 19 trials, 13,000 patients, and the evidence was very, very clear that there was a 29% reduction in target lesion vascularization with intravascular imaging guidance, either IVUS or OCT. And since this is the top level analysis, there was no indirect evidence. So this is all direct level of evidence. If you look now at the IVUS alone versus angio, and OCT versus angio, and then IVUS or OCT from Renovate versus angio, you can see that we do have now indirect level of evidence as well as direct, and overall pretty consistent. And there's substantial reductions, about 30% in target lesion revascularization with both IVUS and OCT, and no significant difference between IVUS and OCT. So here are all of the different outcomes that you can get if you do that similar type analysis, not only target lesion failure. And the most important thing of this meta-analysis was that we saw 45% reductions in cardiac death, and for the first time ever, a 25% reduction in all-cause mortality by the use of intravascular imaging guidance. We also saw not only an 18% reduction in target vessel MI, but for the first time ever, a significant 17% reduction in all myocardial infarctions, and we had nearly a 50% reduction in stent thrombosis and marked reductions in TLR and TVR with intravascular imaging guidance. So strong, overwhelming data. And if you look at OCT guidance versus IVUS guidance, it's more complicated because you've got to look at direct and indirect evidence. But the bottom line is there's no overall differences that we could detect between OCT and IVUS. Maybe a little bit better for OCT for some endpoints, a little better for IVUS for some endpoints, but none of these differences were significantly different. So both of them will give you the same outcomes compared to angiography guidance. We have one more, since this time, large-scale randomized trial of OCT called Occupy, the second largest OCT randomized trial ever done. And in an updated meta-analysis, you could see that this was a very strong result trial, and you can see that now it buttresses the OCT data even stronger. So I have a couple questions to ask. It surprised me when these guidelines came out that they were both only for complex lesions, and it doesn't say anything for simple lesions. So should that be the case? Should we reserve intravascular imaging for complex lesions? And here's the Class 1A guidelines. You could see Europe, complex lesions, in particular left main bifurcations and long lesions. In the US, left main or complex lesions. Well, here's all the characteristics of the patients that were in that meta-analysis that I reported to you. And here's the ones that enrolled non-complex lesions. And about half of the patients enrolled in these trials were not complex lesions. Okay, and we have no evidence that there's overall difference in complex lesions versus non-complex lesions for the relative benefits of intravascular imaging guidance. For example, if you take ILUMIEN 4, the largest ever randomized trial of OCT, you could see subgroups. So here's diabetics, absolutely no interaction, and here's STEMI or non-STEMI. These aren't necessarily complex lesions, but no interaction. So if we look at the complex lesion subsets, such as long lesions versus short, 2-stent bifurcations, severe calcifications, CTOs or not, diffuse or multifocal in-stent restenosis, there were no significant interactions between intravascular imaging or not in complex lesions. Now, what about calcified lesions? Should that be considered a complex lesion subset? And it's funny, I only bring this up because when the European guidelines came out, they said complex lesions were particular left main bifurcations and long lesions. I always think of complex lesions as being calcified lesions as being very complex and that may particularly benefit from intravascular imaging. But there's actually been very few studies of intravascular imaging guidance versus angiography guidance in calcified lesions. So here's that same data from ILUMIEN 4, and while there was no significant interaction in calcified lesions, it actually was the best subgroup of the complex lesions with a trend towards a 50% reduction in events. In fact, if you go from ILUMIEN 4, and if you now look at not only severely calcified lesions, but moderately or severely calcified lesions, and most operators can't really tell the difference from moderate to severely calcified, so I think it's fair to lump them together. This was about half of all the cases enrolled in ILUMIEN 4, and there's a significant 38% reduction in target vessel failure with OCT guidance compared to angiography guidance in calcified lesions. We've now looked at this in the ECLIPSE trial, the largest ever trial of randomized trial in severely calcified lesions. And we didn't randomize intravascular imaging versus angiography guidance in this trial, but it was used by operator preference in about 62% of the cases. And if you look here at the cases in which intravascular imaging guidance was versus was not used, there was a 30% reduction in target vessel failure in an unadjusted analysis. And after we account for all the differences in baseline clinical and angiographic characteristics, there was still a 26% reduction in target lesion failure, target vessel failure. What about OCT versus IVUS? This was kind of interesting. OCT was used somewhat more than IVUS in ECLIPSE, and if you looked at the unadjusted data, it substantially benefited OCT guidance in calcified lesions compared to IVUS guidance, but after adjustment for baseline differences, this 22% difference remained, but it was no longer statistically significant. So in summary, if I was going to really review the evidence-based medicine guidelines as it relates to intravascular imaging in 2025, I'd say that it's very clear now. IVUS or OCT should be used in all PCI cases to optimize lesion preparation and to ensure optimal stent implantation. This will reduce death, MI, stent thrombosis, TLR, and TVR. Efforts should therefore shift not from doing more randomized trials of intravascular imaging versus angiography guidance, but to overcome the impediments to the routine use of intravascular imaging guidance, including getting better reimbursement and doing better training. But we do need some additional investigation to determine the optimal techniques and procedural objectives for OCT-guided and IVUS-guided stent implantation, and to determine whether there are modest differences in outcomes between OCT and IVUS guidance of PCI, and if so, which technique is best for which lesions. Thanks very much.
Okay, thank you, Dr. Stone. So we have around 10 minutes for discussion. So any question, comments from the panel or the floor will be welcome. Yeah, Kubo, please. You can ask there.
I have a quick question to Dr. Stone. Do you recommend the intravascular imaging use in stent patient? Stent patient, and so quick revascularization, reperfusion is needed, and also stent sizing using intravascular imaging criteria is challenging. So
You're talking about STEMI.
STEMI patient.
Yes, actually, there's from large registry series, from the DAP-TDS and other studies, there's actually evidence to suggest that those patients may benefit even more than the chronic coronary syndrome patients. Although I showed you from ILUMIEN 4, ECS, non-ACS, similar relative effects. But it's very important in the STEMI patients because the patients have pain, their adrenaline levels are high, so you have to make sure they're vasodilated to help the intravascular imaging see the maximal stent size that you could use. And without that, we often undersize stents in STEMI, which is one of the reasons why we have high rates of stent thrombosis and restenosis. So yes, I do think it's worth spending the time in STEMI to do intravascular imaging.
Yeah, Greg, if I could just jump in. So besides IVUS ACS, there's the Korea Khmer online registry, and they've published, I think, 7 or 8 papers. The only group that did not have a benefit from imaging were the STEMI patients in cardiogenic shock. But every other analysis that they've done over the last, I don't know, 10 years or more, have shown a benefit.
Yeah, so maybe, in the presentation of Renovate, besides a question to the panel and also to Dr. Hahn, so I was intrigued by the fact that you have these differences according to the MSA, which I think replicates most of the data that we have seen so far. But when you look at the amount of calcified lesions by IVUS that you showed, it's the same. So basically, when I think about under-expansion, I think it's either small vessels, especially when you look at MSA, or severe calcified lesions that you cannot expand the stent. In this case, it appears to be that most of the small MSAs were driven by small vessels. So the question is, are we looking here at the real under-expansion, or are we looking just at a higher rate of TVF, of TLR, related to the stent, the small vessel?
So it means that the impact of baseline characteristics, right?
Well, the vessel size, because when you look at the vessels as well, there were more circumflex, more LADs and less right, which the right you can have a relative huge under-expansion, but you still have a large MSA.
Yeah, thank you for your excellent questions. So, as you mentioned, our results might be due to difference in baseline characteristics. As I presented in my presentation, the MSA less than 5.5 square millimeter was associated diffuse long lesion, small vessel, and LAD lesions. So we cannot overcome the difference in baseline characteristics. But anyway, we have to try the optimized results. And when we incorporated MSA, relative stent expansion, a major malopposition, and major dissection, the only important predictor was the absolute MSA in our analysis.
Dr. Ahn nicely demonstrated the which lesion have to be done by the provisional stenting and two-stent technique. But however, the recent one trial, DCB BIF trial, showed the side-branching DCB treatment is one option. That trial to reduce the event from that kind of patient. So from the ASAN data, I think the larger plaque balloon and smaller MLA patient for the circumflex of the ostium, I think the another option, the provisional stenting and DCB, would be the alternative options. I don't know the why, but Dr. Ahn is not here, so I would like to ask the why he defined the acute event, including the kissing balloon. But is there any consensus for the provisional stenting for left main? Do we have to do the kissing balloon or just to leave it? But anybody, any idea about it? I always ask you, I have to do or just leave it? Any
I
comment?
think that it's a kind of a biased, can be a kind of subjective endpoint, so that it may need further discussion. But I agree that the use of DCB may work, considering the DCB BIF trial. But we have to remember that the DCB bifurcation trial included only a very short side branch lesion, less than 10 millimeter, so that the results may not be applied to large left main bifurcation lesions.
I would like to ask a question to Akiko. So I enjoyed your presentation, but as you mentioned, in the first generation DS era, the stent recoil seemed to be rare, but in the contemporary DS era, you can observe the stent recoil. Even though the contemporary generation DS are much thinner than the first generation DS, but the company claims the radial force maintains the same or even greater than the previous DS.
Do you believe the companies?
But anyway, they claim. And in our practice, I do not see the significant difference in terms of radial force between the contemporary and the previous DS.
So let me ask you a question. If the contemporary DS were as strong as first generation DS, would Boston Scientific have made Megatron?
Yeah, but in my personal experience, I cannot observe any significant difference between contemporary and the first generation DS. So, can you?
How many long-term follow-up paired studies have you done? That's where the data comes from.
Yeah, but I don't have any data. But
Right. So.
yeah, but
Sorry. I mean, this is chronic recoil. This is not acute recoil.
yeah. I just asked a question.
I'm not sure what the question was, but I think, okay, you are saying you don't feel such recoil occur. It's really, I didn't think so too. But when we have the very nice 2 times OCT and very carefully analyze side by side, we see that's data. So I think that that's data, that's real. But contribution is not too much, so I don't think we should overreact. But our data tells us if you are treating the very calcified region, and if you don't treat enough for the calcium before stenting, and then you are stretching the non-calcium side, that's more likely prone to the recoil. So I think that makes sense. So that tells us, thinking that's potential, and then if you treating the very severe calcified region as much as possible, we should modify. And also the osteal region or circumflex ostium, that's probably prone. So it's so maybe no stent or more radial force compared to the very thin stent. That we should consider. But those data has to be prospectively answered. So we don't have data yet.
Yeah. So we have to separate acute recoil, which the engineers call plastic deformation, which is what happens between when the balloon is fully inflated to when the stent establishes a steady state as you're deflating it. That's plastic deformation or acute recoil. Then you have to talk about chronic recoil, which is from that point, that acute steady state, to what happens 1 year later. And they can't be mixed up.
Akiko, I think the question, I understood from your talk that one of the mechanisms you're proposing or could be hypothesized is that there is increase in calcium, and that calcium is pushing the stent again towards the lumen and making the stent smaller over time. So if that is the case, and I understand that sometimes there is a limitation of intravascular imaging because you have the stent and you have to look at the calcium that is behind the stent and you have to compare the calcium at baseline compared to the calcium at follow-up. So there are two questions. First, if I understand that correctly?
No.
No, okay.
Okay, so I think maybe, I'm sorry, my talk was not very clear enough. I think the main mechanism, if you consider baseline follow-up, analyzing the non-calcium side, how big that circumference and follow-up, and calcium side, baseline follow-up, and the majority of the decrease occur non-calcium side.
Yeah.
So why?
So it's the calcium side, the non-calcified opposite the calcified. The calcified is fixed.
Yeah.
The non-calcified seems to get stretched, and then over time, that part recoils.
Yeah, and why this is more in the calcified region is because when you have eccentric calcium, really mechanism is stretching the non-calcium side. And then you get the eccentric stent expansion. That's more likely causing the recoil. That's really stretching the, yeah.
Okay, Eveline, please. Last comments.
Akiko, I was intrigued by your finding that you have a higher incidence in the right coronary artery. Did you had a chance to review the angiograms? Could this somehow be caused by mechanical damage due to the guiding catheter? Because it's the right coronary artery. We have, especially in radial approach, we sometimes have little steering possibility for the seating of the guiding catheter. And on the other side, this is also the artery where most people like to do deep intubation, especially to cross calcified lesions.
Yeah. I think that's yes. And I think when we look into the right osteal in-stent restenosis, as I showed, 25% is due to the fracture or deformation. But that may occur at the time of the index or during the chronic stage. We don't have the serial data for the right coronary osteal data, so that's, I think, we just have the snapshot showing the 25% of the recoil. But I think when we analyze the entire coronary artery, that's the most vulnerable place causing the recoil, probably osteal right and osteal circ. That's our observation. But yeah, anyway.
Okay. So we now have to move on. We have two more presentations. The first by Bill Fearon, CT-based coronary physiology in practice, an update.
Thank you, Gary, and thank you, Kwon, for the invitation to speak about CT-based coronary physiology. I'll try to cover physiologic assessment of coronary disease, briefly talk about CT-based plaque assessment, and finish up with the prognostic value of CT-based physiology and plaque assessment. So regarding physiologic assessment, computed tomography perfusion, or CTP, has a similar concept to SPECT or PET. It does require a vasodilator and extra contrast during the coronary CTA. It can be done static on one image or dynamic on multiple images. It identifies areas of ischemia and has been shown to increase the positive predictive value of the coronary CTA alone while maintaining a high negative predictive value, and has been found to be on par to cardiac MR and PET and better than SPECT. but some of the limitations like needing to give a vasodilator and extra contrast have limited its clinical utilization. And so the more common way of assessing physiology from the coronary CTA is by using various methods for measuring coronary physiology. And so FFRCT was the first one that uses computational fluid dynamics to create a patient-specific model of coronary flow and pressure. Dr. Koo and his team did the first study validating FFRCT in comparison with invasive wire-based FFR and showing that it had a larger or higher area under the curve compared to coronary CTA alone. A follow-up study confirmed these findings in a larger population of patients. And then even more recently, there's been a study comparing FFRCT with other non-invasive imaging techniques like PET and SPECT, again compared with wire-based FFR, and showing that FFRCT had the highest area under the curve. The PRECISE trial was a study implementing coronary CTA and FFRCT, as well as the PROMISE risk score for stratifying patients presenting with chest pain. So there were two pathways, a precision pathway and a traditional testing. In the precision pathway, the PROMISE risk score was used to identify low-risk patients and who didn't require any sort of testing. And then the other group had coronary CTA plus minus FFRCT if necessary. And then traditional testing could have non-invasive stress imaging or go directly to the cath lab. And the primary endpoint was death, MI, or a cath without obstructive coronary disease. And what you see is that at 1 year, the precision pathway resulted in a 70% reduction in this primary endpoint, mostly due to a reduction of cath without obstructive disease. If you look at the two strategies shown here, you see that with the precision pathway, you identify fewer patients that require cath, however, more patients that require PCI, similar numbers undergoing CABG, and fewer patients that are found to have non-obstructive coronary disease. So based on all of these data, the recent guidelines now give coronary CTA a class 1 recommendation, and the addition of FFRCT class 2A in the American guidelines from 2021, and the recent European guidelines give it a class 1B. Now, there are other companies that I haven't spoken about, such as Clearly, that have developed algorithms to also measure ischemia based on the coronary CTA. And HeartFlow can also provide plaque assessment, as shown here. And there's a lot of interest in incorporating the plaque assessment with the physiology. Clearly also provides plaque assessment in conjunction with their ischemia testing. And like I said, studies have shown that there's a correlation between abnormal physiology and abnormal plaque. These are data looking at the delta FFRCT and its relationship with plaque burden and also with high-risk plaque. And you see the greater the delta FFRCT, the greater the chance of having high atherosclerotic burden or a high-risk plaque. And finally, I would just like to finish up by talking about this key question: can we predict myocardial infarction? And again, Dr. Koo's led the way in this area. This is the Emerald 2 study where they looked at 351 patients who had had a coronary CTA at least 1 month or up to 3 years before having an ACS event. And then they identified the culprit lesions at the time of their ACS event based on coronary angiography. And they developed an artificial intelligence-enabled quantitative coronary plaque and hemodynamic analysis to predict vulnerable plaques or plaques that would go on to cause ACS. And this was compared with a reference model that included both this coronary artery disease reporting and data system, basically an assessment of stenosis severity, as well as 2 or more adverse plaque characteristics based on the original coronary CTA. And you see that both stenosis severity correlated with a culprit lesion, so more severe stenoses were more likely to cause an ACS event, as well as high-risk plaque features. So if you had 3 or more high-risk plaque features, you're also more likely to have a culprit event, or that lesion was more likely. And the 2 of these are additive. So if you had both a severe stenosis and multiple high-risk plaque features, you had the highest chance of that lesion becoming a culprit lesion. Now, the AI-QC-PHA analysis that they performed identified a number of features that were predictive of a culprit lesion, the delta FFRCT, plaque burden, total plaque volume, low attenuation plaque volume, and the average % total myocardial blood flow. And they found that this, in fact, improved the ability to predict culprit lesions above that reference model, including stenosis severity and adverse plaque characteristics. So to summarize, coronary CTA plus FFRCT provides accurate, non-invasive detection of myocardial ischemia, a pathway including CT-based coronary physiology to evaluate patients with chest pain results in more accurate and efficient assessment, and the incorporation of plaque burden and plaque characteristics to CT-based physiology may augment our ability to identify high-risk plaques which require aggressive therapy. Thanks for your attention.
Thank you, Bill, for a very comprehensive lecture for the CT-based coronary physiology. And next speaker will be Dr. Ziad Ali from the United States, and he's going to talk about the newcomer photon counting CT. Ziad, please.
Thank you very much. So I've had the fortune of being involved in a few sort of game changers in interventional cardiology. I really genuinely believe photon counting detector CT is one of those. We had CT, became board certified CT in the mid-2015-ish, but really didn't find it that helpful in procedural planning, to be very honest with you. There was just too many limitations, but photon counting has really changed that. Okay, so what I'm going to talk about quickly are principles of photon counting detector CT. This is a new hardware. The clinical impact and diagnostic performance of photon counting CT. How does it actually apply to your clinical practice? Why is it of benefit? And what are the potential applications in terms of coronary disease, but also outside of coronary disease? So let's start a little bit with principles. So obviously CT's been evolving. First we had a spiral CT, then we went to multi-slice CT, and then dual source CT, which made the acquisitions much more quick and also allowed us to get a full coverage of the heart with less artifact, but really there was a modest improvement in the resolution, and ultimately for something as small as the coronary artery, we need resolution. Photon counting CT is an entirely new hardware. It's not a software iteration that we've had over the multiple years. This is a different way. We're actually counting photon. We're not counting light anymore, and as a benefit of that, you have a significantly improved resolution. So in general, what happens is in an energy detector CT, the one you're normally used to, we use a scintillator. And so what happens with a scintillator is that as light interacts with the photodiodes, it creates a signal for you, okay? And so what happens in that situation is each light signal fits into a bucket. So rather than you counting each photon, you're just counting a grouping of light. And so that's what happens. This energy information is lost as these signals are combined in each projection. So you're putting energy into buckets. On the contrary, so you have this two-step conversion of X-rays to light to current. On the contrary, photon counting CT counts the photon directly. And by impacting and producing a charge proportional to the X-ray energy, what happens is we are able to individually determine the impact for each photon and collect the energy information for that. And as a result, there's a single step and there's a direct conversion of X-rays into current. So what are the benefits of photon counting CT? You have a smaller detector with pixels. You have the elimination of electronic noise. We have this thing called spectral sensitivity, which means that we can look at a specific energy level which may be very good for calcium, for example, or maybe very good at looking inside stents, or maybe looking at high-risk plaque or neointima. All of these we can look at separately because we're not putting things into bucket anymore. And I think a picture speaks 1,000 words. And so this is an example of one patient who's got an energy detector CT in 2023 and then has a photon counting CT in 2024. This is a recent from our JACC publication. So improved spatial resolution, reduced electronic noise, and decreased blooming artifacts. And obviously you can see on this example, the big problem is calcium. So calcium is the hallmark of the presence of coronary artery disease, hence calcium scoring, and you can't see inside. So all of these algorithms are guesses. Here we can actually look inside the lumen. So if we go to the clinical impact, we tested this in a study design at St. Francis Hospital, where what we did is look at all of the CTs that we'd done prior to the implementation of our photon counting CT and all of those after the implementation of the photon counting CT. And we looked, how did it actually impact our practice in terms of the number of invasive coronary angiograms and the number of patients who underwent PCI. So this is not a small study. We're a big center. We do about 6,000 coronary CTs per year, about 4,500 coronary, and we examined almost 8,000 patients who had energy-detected CT compared to photon counting CT. A lot of the work is done by Koshiro Sakai and by Dusip, who are both here. And what you'll see is with regards to indeterminate lesions, energy detector CT is more likely to be called indeterminate by the reader. Why? They can't see. You simply don't have the resolution for them to be able to make a call. And when we look at the impact of this on the clinical practice, you can see that there's a modest reduction in invasive coronary angiography referral. But if you do get referred after a CT with photon counting, you're more likely to get a PCI, which means essentially the resolution allows the reader to make a call, and that call is more likely to lead to a clinical impact. So overall, the rates of unnecessary invasive coronary angiography decrease significantly. This is a summary of the diagnostic performance for coronary disease. You can see that there's an improvement in the diagnostic accuracy, an improvement in the specificity, and an improvement in the positive predictive value. I would also like to note that the sensitivity of both these devices is very, very good, and so hence the increase over the last several years of CT in general. So when we did an IPTW adjusted analysis, you can see that the referral to invasive coronary angiography is independently predicted by the use of a photon counter, receiving revascularization, and a more accurate diagnosis of CAD. So to finish off, what are the applications of photon counting CT in interventional cardiology? Well, one of the things that we want to look at is evaluation of heavily calcified arteries. Right now, when we had a high coronary calcium score, we would basically, our radiologists previously would actually take people who had a calcium score of greater than 450 and not do the coronary CT. They would just stop, say, it's too high, you need to use another modality. Now that is really being obviated by this improved resolution. In-Stent restenosis, as you know, the current guidelines suggest that you should not be performing CT in patients with stents less than 3 millimeters. We are challenging that dogma and have that publication in review at JACC Imaging. PCI planning, and then finally structural interventions. So when we looked in our data set of photon counting CT in calcified vessels, we found the same phenomena, that your invasive coronary angiography referral was lower in the photon counting CT group because we were able to make a plan. And the revascularization, if referred, was indeed higher. So your unnecessary invasive coronary angiography is significantly reduced using the photon counter. So let's see why that is. Clinically, that's because if you do a non-invasive test and the radiographer or the cardiologist reading can't tell, they will always side on caution to ask you to cath the patient because they want improved sensitivity. Nobody wants to miss a patient who has significant coronary disease. So they go to the cath lab, they get more angiography. That's a waste of time for us, and so we're trying to reduce that. If you look at the vessel level coronary calcium scores of less than 100 or greater than 100, you can see that you have the same benefits even in patients who have more calcium. We showed this example before, but look at the resolution of the calcium itself. Something that Carlos has been working on and we've been working on now quite carefully is the density of the calcium, which we hope to give you more information soon. So here's a case example of how we actually apply this. This is using the spectral information. By using spectral information, we can actually do pure lumen, which means we can completely eliminate the calcium. We pick the spectral that fits calcium, we remove it, and then the artifact that's created by the bloom is eliminated so we can see the stenosis much, much more clearly. This is obviously something that's in evolution, but we're finding things like this ability to use pure lumen be of major benefit. In-Stent restenosis, very quickly. This is currently under review at JACC Imaging. We're proud to say that you no longer have to worry about how big the stent is if you have a photon counter. You can look in a 2.25 millimeter stent, or you can look in a 4 millimeter stent. We're in the process of comparing this directly to OCT as the gold standard, and so far the measurements tend to be excellent. I will say there is subtle things that we need to learn. So these different spectrals actually have a major impact on the measurements, and we're still learning which one is probably going to be the best. It looks like BV68, but more on that to come. This is our In-Stent evaluation that's currently under review. This is 143 paired cross-sections where we have OCT. There's a very strong correlation with OCT measurements, especially with the sharper kernels. Okay, finally, diagnostic performance of photon counting CT for ISR actually looks very, very good. You can see the sensitivity and specificity here and the diagnostic accuracy ranging in the 90% region for stented level patients. And they have a good performance regardless of the stent diameter. You'll notice that patients who, and this is per the guidelines, patients who have a stent that's less than 3 millimeters, the performance is basically exactly the same as those that is greater than 3. So as a result, this all has to do with the resolution and the hardware change rather than the software change. Look at this incredibly beautiful example of a non-ISR in ultra-high resolution mode. Ultra-high resolution mode actually gets you down to 0.4 millimeters. I would argue that there's no coronary angiogram benefit of the coronary angiogram in this patient. We have completely changed our practice. In patients who have post-procedure chest pain after stenting, we no longer bring the patients back for invasive angiography. They go to the CT scanner. Here's another example of a patient with a photon counting CT where you can see 2 stents, and also you can see the calcium surrounding these in BV56. Another case example in ultra-high resolution mode where you can see the neointima very, very clearly. You can see a focal restenosis at the proximal edge of the stent, all of which really kind of allows us to do procedural planning up front. Here's some case examples of mild neointimal hyperplasia, which you can see. So not only are we looking at this as a potential for clinical use, we're also thinking about using this for follow-up angiography. So all the studies that we did years ago about doing follow-up angiograms, if we want to look at patency and look generally in terms of percent diameter stenosis, we should be able to move towards CT. Very quickly, I'm going to skip through this, but for PCI planning, we're now using this regularly. A lot of this credit goes to Carlos, who kind of developed this field, but we get a photon counting CT scan, we plan our procedure, and the MLD of the MLD max we do beforehand. We determine the lesion preparation before, we pick all our stents, and we've made and used CT much more like TAVR. We have all of our equipment planned up front in the room. Everybody, we're there to execute. We are no longer planning during the PCI as to what we need to do with imaging. We'll obviate the need for imaging in the pre. And I'll skip structural interventions for the sake of time. So in summary, photon counting CT is new hardware. It's not a software iteration. The spatial resolution actually has a clinical impact. It's not just sort of a theoretical impact. And the clinical impact of this is compared with energy detector CT, we have improved specificity and positive predictive value, and we clinically reduce the number of invasive coronary angiograms and unnecessary caths. Thank you very much.
Thank you, Ziad. I think we can have some minutes to discuss about these two interesting topics. Questions, comments?
Yeah, I have a question for the Dr. Fearon for the first topics. Thank you for your nice lectures for the reviewing the CT-based coronary physiology. But I have a short question. When we consider the FFR in the intermediate region, we only consider the FFR for the intermediate region. Do you think we need to evaluation for the CT FFR for the under 50% stenosis? Because you have a review about the prediction of MI or cardiac event with the coronary CT, but some reports says frequently CT may have some increase of the cancer issue or other things. So we trying to CT FFR. Which patient selection do we need for the CT FFR?
Yeah, that's a great question. I think, from Dr. Koo and Carlos and others, we've learned that the delta FFR, or the pressure gradient across a lesion, may be just as important as the absolute value. And so if you have less than 50% stenosis, even if the FFR is 0.82, but it has a very high delta FFR, that could identify a higher risk lesion. So I think there could be a role. And then certainly, we've learned that in left main or proximal LAD or other lesions that are supplying a large amount of myocardium, that they don't need to be as severe as classically thought, and can still be ischemia producing. So yes, I certainly think we need to apply in those settings.
Then one more question. Then who decides to going to CT-FFR or not when we see the CT angiography? Because in our countries, the radiologist decided to the 50% or not. Then the radiologist decide to going to CT-FFR, or the cardiologist decide to CT-FFR going or not?
Yeah, I can't speak to all centers in the United States. At our center, it's a similar way. The radiologist is the first person, but some of our cardiologists also read the coronary CTAs, so it depends on who's doing the initial reading, but the initial reader is the one who decides. But we do, if I've ordered one and the radiologist was the initial reader, and then when I'm reviewing it, I have questions, I always have the option of still going back to the FFR CT. So, and I was going to ask Ziad about his data, if that's okay, regarding that improvement in diagnostic accuracy of the photon counting. Was that is that just based on the coronary CTA alone, or that you're making the decision, or is it using some sort of physiology additional to that? And did you find that there are fewer cases that are being rejected from, whether it's HeartFlow or Clearly or another company, because they're able to interpret more of them?
Yeah, a great question. Thanks, Bill. Koshiro, who's was our fellow for this project and the first author of the paper in JACC, we had the same question. So we're actually prospectively doing a HeartFlow study to see if the diagnostic accuracy of HeartFlow improves because you don't have the same artifacts. How many patients we have? Like 50 now, something like that. Yeah, so we're getting closer. I think that's an excellent question. In that specific study, it was just by angiography. We didn't add up whether or not patients had FFRCT, but I think it's an extremely valid question. And if I was to bet, or as a scientist make a hypothesis, it's going to be better.
So it's a game changer. So that it's good that you're moving into a new field. But along with that previous question, that if any kind of CT-FFR system having a new segmentation information, which is better than the previous information, but all the CT-FFR system has been trained with the previous system, and so if they adopt, I don't know the results of your study, but if they want to adopt the kind of new system with new segmentation information, practically they have to change the boundary condition as well. So how do you think about that kind of changes?
So you're absolutely right. And this new technology introduces a new problem, and that is that all of these are validated on energy detector CTs, and now you've come up with something with such high resolution. Do we need to reinvent the wheel, or do we just assume that it's an iterative improvement? So some of the answers that I've got that are interesting come from Charis Antoniadis, who's doing the work for Caristo. And he says if you look at the difference between scanners that are energy detector, like a Canon versus a Toshiba, they're so different, even in themselves, that basically you're putting this large bucket of sort of messy data together and still coming out with these results. So I think the good news is what Bill is alluding at. It's probably going to get better. even based on the current technology. But if we were to redefine the algorithms based on photon counting CT, I think our diagnostic accuracy would be extremely high.
You know, we went through this with X-ray. We went from standard CRT to flat panels. And it's not as if the algorithms changed. We just realized we could see better.
Yeah, so I think, Gary, what is becoming obvious is that CT is not anymore a rule-out test. I think that I appreciate that TCTAP included this session in the program, because I think that more and more we're going to see how us as interventional cardiologists will use the CT for enhanced diagnosis, follow-up stents, PCI planning, and I think that the potential is huge. So it's up to us, again, to define the way that we're going to learn this. And the reason is I train the US CT, and the way that you train CT is not really the way that you're going to be using the CT as an interventional cardiologist. So this will require a complete, we have to redo all the way that we think we should learn CT relevant for PCI procedures, where calcium, I think, will play a major role in that learning process.
And I also appreciate very much TCTAP putting this session because, and Carlos and this resonates for both of us, we meet with the CT companies all the time, but they are completely dedicated to the imager and the radiologist. The radiologist doesn't care how big of a stent I'm going to put in. That's not their interest. Their interest is the plaque, how much it is, what the CAD-RAD score is. They want to get their job done and shift it over. But it comes to you and I, and we want to know, well, wait a minute. I want this information like a TAVR. So what view should I look in? How big should my stent be? What post-dilation balloons do I need? And do I need to do atherectomy or IVL? I mean, those are our questions. And then we're finally getting there. So the benefit for us in that regard is companies like Clearly and HeartFlow are really kind of investing in that and now realizing what a big part of this could be for interventional cardiology. So I suspect this space to become bigger in our interventional meetings.
Yeah, I mean, being somebody who's gone through many generations of things, it's really an operational issue within each individual institution. I mean, as far as I'm concerned, remember, cath labs started in radiology. Echo labs started in radiology. Nukes started in radiology. None of them came into their own until they left radiology and went into cardiology.
I mean, you're making a bold statement. I couldn't agree more. I think the reason we have had the traction and ability to perform meaningful research in this space is all of our CTs are read by cardiologists. We have a division of cardiovascular imaging. We hired someone with an interest in this, and they blazed the field forward. But we recently did a HeartFlow study where half of the studies were read by a cardiologist, Omar Khalik, and half were run by the radiologist. You cannot believe the difference in the reports. The reports from the radiologists are totally qualitative, they're kind of wishy-washy, all over the place, and Omar creates a grid for us for each branch with a stenosis and the FFR next to it.
Have you ever looked at a nuke report read by a nuclear medicine physician? Okay, great session, great talks, great panel and great audience, and I encourage you all to go to the main arena at 10:30 for the 30th anniversary celebration.